Well, welcome everybody to the traumatic brain injury session of the Brain Conference. We've got some fantastic speakers, 5 speakers this afternoon, and we'll get going in a second. I just wanted to mention we've also got a range of really good posters, so I'd encourage people to visit the posters. There's a poster session this afternoon and also one tomorrow morning, and we have a roundtable poster discussion just at 10 o'clock tomorrow morning if people would like to come along to that and hear about the posters. So without further ado, I think we'll get going. So first up, we have Brian Edlow, who's joining us from Massachusetts General Hospital in the States. Brian's going to tell us about consciousness and connectivity, I think. So over to you, Brian. We'll have a little bit of time for questions after each of the talks. So please type your questions into the chat on the platform. Off we go.
Hello, everyone. My name is Brian Edlow, and I'll be presenting on mapping the connectivity of consciousness. The work that we'll be discussing was funded by a variety of federal, foundation, and departmental sources, and I have no financial disclosures or conflicts of interest to report. There are 4 objectives for today's talk. First, we'll be discussing the clinical motivation for the development of advanced neuroimaging and electrophysiologic tools aimed at detecting consciousness in patients with severe brain injuries. Second, we'll discuss the state of the science in this field. Third, how these techniques can be used to guide the selection of targeted therapies aimed at promoting recovery of consciousness. And then finally, we'll discuss some future directions. How can we use these tools moving forward to improve care for patients with severe brain injuries? The motivation for this work is that we and other labs around the world that are studying patients with severe brain injuries aim to improve acute care and long-term outcomes for this patient population. We also aim to support families and surrogate decision makers who face a fork in the road, life or death decision, typically within the first 7 to 10 days of their loved one's arrival to the ICU. Do we continue with aggressive life-sustaining therapy, which typically involves placement of a tracheostomy and a feeding tube? Or if even the best case scenario for a long-term quality of life is one that would not be acceptable for that patient, then do we transition to comfort-focused care and allow that patient to pass away peacefully in the ICU? The problem that we face is that our diagnostic tools fail to detect preserved brain networks in many patients that could support their long-term recovery. Similarly, our prognostic tools often fail to predict outcomes reliably. And so I begin and end every family meeting with a message of humility and an acknowledgement that prognostication in the ICU is an uncertain art and science. The literature shows us that other ICU clinicians take a more pessimistic approach to prognostication. This prognostic pessimism is evidenced by the largest study to date looking at causes of death for patients with severe traumatic brain injury in the ICU. This is a study of over 600 patients at level 1 trauma centers in Canada, and the investigators found that 70% of all deaths in this population were attributable to withdrawal of life-sustaining therapy. So were all of these patients destined to have a poor outcome anyway? Well, only about half had an unreacted pupil, about a quarter had evidence of herniation on CT, 2 of the findings that we typically associate with a devastating outcome. And what emerges when you read the discussion of this paper is that it is the manner in which we, the clinicians, are communicating with families that is a primary determinant of decisions to withdraw life-sustaining therapy. So let's be clear about the stakes of an incorrect prognosis. If we are overly pessimistic, then a patient who had the potential for recovery may have life-sustaining therapy prematurely withdrawn in the ICU. On the other hand, if we're overly optimistic, then a patient could end up in a vegetative or minimally conscious state that he or she would never have found to be acceptable. So for the next 15 minutes, we're going to be talking about the state of the science in this field. How are these advanced imaging and electrophysiologic techniques being used to improve the quality of our diagnosis, such as by detecting covert consciousness? How are they being used to improve the accuracy of prognostication and to select therapies for targeted management? First, diagnosis. Many of us are familiar with the Glasgow Coma Scale score, or GCS. This was a scale that was developed for rapid triage decision-making. Does this patient need to go to the intensive care unit? Does he or she need an intracranial pressure monitor or to go to the operating room for decompressive hemicraniectomy? These are the types of decisions that can be informed by a GCS assessment, typically performed within about 30 to 60 seconds. If our patients can tolerate being off of sedation for long enough, and this may take about a half hour, then we will perform a more comprehensive behavioral assessment with the Coma Recovery Scale Revised, or CRSR. And multiple studies have shown that the CRSR detects subtle signs of consciousness, such as tracking with gaze by the use of a mirror, as shown here in this schematic, about 40% of the time when a patient does not appear to be conscious based on a standard GCS type assessment. What if we could then perform task-based functional MRI for each one of these patients, where we place earphones in the ears, as shown here in the schematic, and we ask the patient to imagine performing a motor imagery task, like imagine opening and closing your hand. Multiple studies have now shown that about 15 to 20% of the patients who appeared unresponsive on the GCS and the CRSR will show volitional modulation of their brain activity during a task-based functional MRI assessment. So what do we call this phenomenon? What is the diagnosis? The most commonly used term is covert consciousness. Another term proposed in 2015 by Nico Schiff at Cornell is cognitive motor dissociation, the idea that there is a higher level of cognition in that patient than their ability for motoric expression. And what I'd like to show you here on this slide is a feel for the types of data that we can acquire when performing fMRI assessments. This is from a pilot study performed at Mass General Hospital in Boston, Massachusetts between 2012 and 2014. We're looking at the motor imagery fMRI data in this column. We also played spoken language and music stimuli for these patients, as shown in these respective columns. And we performed the same assessments using EEG, but for the purpose of this slide, we're going to focus on the fMRI data. In the top row, we see a representative healthy subject. This subject responds bilaterally within the superior temporal gyri to language and music. And during the motor imagery task, we see activation within the supplementary motor area and premotor cortices. The next row is a patient who had just started to follow commands on the bedside behavioral assessment, indicating a high-level minimally conscious state. He also responds to language and music, and although his response is less robust to the motor imagery task, we again see SMA and premotor cortex activation. The fMRI data are consistent with the behavioral data. We have not learned anything new from fMRI. The third row is a young woman who was an unhelmeted motorcyclist who crashed into a wall. Her bedside behavioral assessment suggested a vegetative state right before the scan, and yet here are her fMRI data. She responds to language and music, not just within primary auditory cortex and Heschel's gyrus, but in association cortices and Wernicke's area. And I should mention this is radiologic convention, where this is the left hemisphere. And she also shows this area of activation within the premotor cortex, evidence of covert consciousness. She goes on after a lengthy inpatient and outpatient rehabilitation to fully recover consciousness, communication, and is back to being functionally independent. The next patient is a young man who was a pedestrian hit in a crosswalk. At the time of his scan, he had just started to localize to noxious stimulation, but he showed no signs of comprehension or expression of language. Yet here are his fMRI data. This was performed 25 hours after his injury. We see bilateral activation to the language stimulus. We see unilateral activation to music. This happened to be the classical music piece we played for him. He happened to have played in his high school orchestra as a cellist. He does not respond to the motor imagery task and thus does not meet criteria for covert consciousness, but I would argue that we have still learned something new here. This patient who showed no signs of language comprehension or expression now shows us that his neurons within Wernicke's area can process or respond to stimuli. And while this does not prove that he is conscious, at least that's the consensus in our field for the passive response of the brain to a stimulus, it still shows us that those neurons may provide a functional architecture for long-term recovery. And indeed, after a lengthy inpatient and outpatient rehabilitation, he too goes on to recover consciousness, communication, and becomes fully independent, graduating from college and returning to the workforce. The last patient was in a comatose state based on her bedside exam at the time of her scan, and she does not respond at all to language, music, or the motor imagery task. She too, after lengthy inpatient and outpatient rehabilitation, goes on to graduate from college and fully becomes independent, and rejoins the workforce. And I always end the slide with that case because it's important to point out that these techniques, like any other diagnostic or prognostic technique that we use in the ICU, has fundamental limitations. The most notable of which, in my opinion, is a high false negative rate. In fact, if all of us on this Zoom right now were to undergo this motor imagery test, 25% of us would have this result, a negative result, either because we're sleep deprived and we're falling asleep in the scanner, or we're not paying attention, or we're not trying hard enough. In this young woman's case, she happened to be on a propofol drip, and that may have contributed to the absence of a response. And when we sit down to speak with families about the results, and I should mention that we have permission from our institutional review board to do so, and of the 75 or so patients that we've studied since 2012, every single family has requested access to these results as part of our research protocol. When we sit down to discuss the results, we always counsel families at length that a negative result does not predict a poor long-term outcome because of these potential false negatives. It's also important to consider that it requires a large team effort, and it is quite challenging from a safety and a logistical standpoint to perform these fMRI assessments. Just the act of transferring a patient from an ICU bed to an MRI scanner table, as shown here, requires the expertise of ICU nurses, MRI technologists, and respiratory therapists, and the dislodging of any of the lines, tubes, or drains connected to this patient could cause a serious adverse event. Many of our patients can't tolerate lying supine long enough to undergo an fMRI because of elevated intracranial pressure. And so these safety and logistical considerations have been a major motivation for the development of task-based EEG techniques to detect covert consciousness. Some representative data of what these EEG experiments look like are shown here. And I'd like to share with you 3 of the key findings from the last decade of work in this field. First, there's that 15 to 20% number again, the percentage of patients who appear unresponsive on bedside exam, who then show signs of covert consciousness with task-based EEG. Second, covert consciousness is more commonly detected in those patients with a traumatic etiology of their brain injury as compared to a non-traumatic etiology. And third, there is that 25% false negative rate again. Whether it's with task-based fMRI or EEG, that is the percentage of healthy controls who do not show a volitional response. So why does this matter? Why do we need to get it right in the ICU? In other words, is diagnosis relevant to prognosis? Well, here are some behavioral data from Giacchino and Kalmar in 1997, where they looked at 70 patients with severe traumatic brain injury. On the x-axis, we're looking at the number of months post-injury. On the y-axis, the disability rating scale score, where higher scores indicate more disability. The blue bars represent those patients who were in a vegetative state when they arrived at inpatient rehabilitation, and the pink bars indicate those who were in a minimally conscious state when they arrived at inpatient rehab. Not surprisingly, both groups had high levels of disability at 1 month post-injury, but by 1 year, there is a significant dissociation of these bars, such that those who were initially in a minimally conscious state when they got to inpatient rehabilitation had far less disability at 1 year. In fact, 10% of the group that was in a minimally conscious state on arrival to inpatient rehab had no measurable disability at 1 year. So we've talked now about how signs of overt behavioral evidence of consciousness in the ICU can predict long-term recovery, but what about covert signs of consciousness? These data are from a landmark paper by Jan Claassen and colleagues at Columbia, published in the New England Journal of Medicine in 2019, where they looked at a cohort of over 100 patients with mixed etiologies, and again found that 15% of the patients had evidence of covert consciousness. And the key finding here was that the odds ratio was 4.6 for a favorable outcome on the Glasgow Outcome Scale Extended at 1 year for those patients who had evidence of covert consciousness in the ICU as compared to those who did not. The first evidence that covert signs of consciousness early on may predict long-term recovery, just as overt signs of consciousness do. This next study from Sokoliuk and colleagues, this is from Damian Cruz's lab in Birmingham, looked at a language stimulus administered in the ICU to a small cohort of patients with severe TBI, and they looked at the time-locked EEG responses to words as compared to phrases, as compared to sentences, as shown here in this representative healthy control analysis. And they found that the cortical responses to this elegant language paradigm explained 30% more variance in 6-month outcomes than did the GCS scores performed in the ICU. The first evidence that early signs of covert processing of a language stimulus in the ICU may similarly predict long-term recovery. It has been remarkable to see the degree to which clinical guidelines are now starting to embrace these types of advanced assessments. The 2018 guideline led by Giacchino and colleagues that was endorsed by the American Academy of Neurology, American Congress of Rehabilitation Medicine, and the National Institute on Disability, Independent Living, and Rehabilitation Research stipulated that task-based EEG and motor imagery fMRI have a role to play in the clinical evaluation of patients with disorders of consciousness. Now, it's important to point out that the levels of confidence in these recommendations were moderate and low, respectively, for EEG and fMRI. And it's important to consider that this guideline pertained to patients who are 28 days or later into their recovery. Fast forward to 2020, the European Academy of Neurology puts out its clinical guideline led by Conziella and colleagues, and they too endorse a multimodal approach characterized by a comprehensive behavioral assessment, structural and functional MRI, as well as PET and even TMS EEG whenever it's feasible to do so. And I'd like to quote from this European guideline because it represents such a sea change in our field. The authors state, quote, "In conclusion, a given patient should be diagnosed with the highest level of consciousness as revealed by any of the 3 approaches: behavioral, EEG, and neuroimaging." So this is the type of multimodal assessment that is now being recommended by the guidelines: a comprehensive behavioral assessment with the CRSR, as well as task-based EEG and fMRI when feasible. Many of us were trained to think about the assessment of consciousness as proceeding along 2 axes, those of overt cognition and motoric function, but we're now being asked to consider a 3rd axis, that of covert cognition, which can be assessed with fMRI or EEG. So how can these tools be used to guide the selection of targeted therapies? Well, we recently launched a study looking at intravenous methylphenidate in our neuro ICU here at Mass General, where we're testing the hypothesis that those patients with partially preserved connections from the dopaminergic ventral tegmental area to rostral sites in the diencephalon, forebrain, and cortex, those are the patients who are likely to respond to IV methylphenidate, because you need to have some intact axons in order to release dopamine at the synapse for this dopamine reuptake inhibitor to be efficacious. We're also collaborating with investigators at UCLA, led by Martin Monti, Caroline Schnakers, Paul Vespa, and colleagues, who have been performing experiments using low-intensity focused ultrasound pulsation, or LIFE-UP, for non-invasive stimulation of the central thalamus. And one of the hypotheses that we'll be testing moving forward is that patients with preserved thalamocortical connectivity are more likely to respond to this targeted thalamic stimulation. We call this approach the connectome-based clinical trial platform. And here is an example of the type of patient whom we would predict would respond to methylphenidate. We're looking at diffusion tractography data from a lateral perspective here, and we're looking at tracks that were generated by a seed placed in the ventral tegmental area. First, we notice that the patient with severe TBI has far fewer tracks connecting the VTA with the cortex. But we also notice that this patient has some preserved connectivity with the cortex, including with the medial prefrontal region. And so this is the type of patient whom we would predict would be a responder to methylphenidate. So where do we go from here? This is our moonshot MRI scan, our 100 micron MRI. These data were acquired, pardon me, over 100 hours of data acquisition in a formalin-fixed post-mortem human brain specimen. Even our most dedicated volunteers cannot lie still for this long. And so we likely won't see resolution this high in vivo studies for at least several years to come. But the reason I showed this set of images, which was acquired in collaboration with a large team of MRI physicists, engineers, and other neuroscientists at the MGH Martino Center, is because of how we can use these types of ultra-high resolution images to guide the selection of future therapies. So here's one such example. This work was led by Andrew Lee, a postdoctoral fellow in our group. And what Andrew did was he analyzed the highest resolution resting state fMRI data set that we could identify. This was a human connectome project data set, freely available open source on the internet. And we looked at 86 subjects scanned at 7T and first mapped the cortical connectivity of the default mode network. And then we asked the question, can we identify subcortical regions of connectivity with the cortical DMN? Because those subcortical sites may provide future targets for stimulation of the cortical DMN. So what we're going to be looking at here are regions of subcortical DMN connectivity superimposed on our 100 micron structural high resolution map. In red yellow are areas of positive correlations with the cortical DMN nodes. In blue are areas of negative or anti-correlations with the cortical DMN nodes. We see positive correlations in the dorsal raphe, in the ventral tegmental area, in the lateral hypothalamus, in the basal forebrain. And as we get to the more rostral cuts, we see these positive correlations in the central thalamus, consistent with prior connectivity studies in non-human primates. And so what this map provides us is an opportunity to begin to test neuroanatomically precise targets for future invasive and non-invasive therapies. Let's take a step back and consider what is our responsibility to patients and their families as we treat patients with severe brain injuries and disorders of consciousness. We've discussed how many academic institutes, both in the US and in Europe, are now endorsing this type of approach where we apply advanced imaging and electrophysiologic techniques to the detection and prediction of recovery of consciousness. One US government institute has similarly endorsed this type of approach, and it has been inspiring to see the degree to which leaders in our field, like neuroethicist Joe Fins, are now speaking at national and international conferences about access to these techniques as a civil right for these patients and their families, akin to the Disability Rights Act passed by the United Nations in 2008. Now, there are profound ethical questions that we will face as a community moving forward. For example, how do we ensure that patients have equal access to these types of techniques if they're at centers that don't have these types of capabilities? And I look forward to discussing these types of questions with you in the Q&A. I'd like to thank you for your attention. And if you'd like to learn more about our research, you can look, here is our lab website, and here is our Twitter handle. Thank you again for the opportunity, and I look forward to the Q&A.
Well, thank you very much, Brian. It's really a fascinating talk, like always. We have time for, I think, one or two questions. There's a question on the chat from Dr. Graham Warner. Do we need to reevaluate he squeezed my hand doc, or is it always frontal denervation?
Thank you, Dr. Diaz-Arrastia, for your kind comments. It's an honor to be here. And I think it's a very important question that I'll take in two parts. First, with respect to whether we need to reevaluate whether he squeezed my hand doc is the only means of assessing consciousness. I would argue that there's compelling data at this point that the behavioral exam, while it will always remain a foundational element of our assessment, is not telling us the full picture of whether that patient is conscious or not. And with multiple studies now showing that 15 to 20% of patients who appear unresponsive on the behavioral assessment can show volitional brain activity with task-based fMRI or EEG, I think it provides quite a compelling reason for us to pursue these advanced techniques. And the clinical guidelines are now reflecting that, both the 2018 guideline from the United States and the 2020 guideline from the from Europe. With respect to the second part of the question, is it always frontal denervation? This is an unanswered question in our field. What is the pathophysiologic basis of covert consciousness or cognitive motor dissociation? And I would point you to a very elegant paper by Davinia Fernandez-Esvejo and colleagues in JAMA Neurology a few years ago, where they showed that there is a preferential disconnection of the thalamus from the supplementary motor area, a preservation of supplementary motor area connectivity in the presence of a disconnection between the thalamus and the primary motor cortex in these patients. And that might provide a structural basis for this phenomenon of covert consciousness. Thank you for the interesting question.
Thank you very much. There's another question from Dr. Spatika Jajaram. Great talk. In the task-based fMRI assessment, do you study mirror neuron activity?
It's a great question. I'll give a brief response because I know we're short on time. The short answer is no. Our fMRI paradigms and those that we built upon, Adrian Owen, Stephen Lorry's, Nico Schiff and colleagues, are really looking at whether there is a response or not to language or to motor imagery. We're not looking at specific cortical layers or specific populations of neurons. For that type of work, I would point you to John Palomini, a colleague and friend at Mass General Hospital, Laura Lewis, who's at Boston University, are doing some really elegant experiments with ultra high spatial and temporal resolution fMRI. A lot of that work though requires 7 Tesla scanners, and we simply don't have access to that type of hardware in the intensive care unit.
All right, thank you very much. I think that's all for our questions. It looks like we're on time, but let's go on ahead to the next talk, which is the Data Blitz by Dr. Francesco Roselli from the University of Ulm, and the title is Chemogenetic Control of Cortical Microcircuitry in Neurotrauma Enhances Neuroprotection and Reduces Reactive Microglia Through Neuro-glial Crosstalk Modulation. Dr. Roselli.
Hi everyone, and welcome to my Data Blitz presentation. My name is Francesco Roselli and I work at Ulm University. So a conceptual question in the field of traumatic brain injury is whether, for therapeutic purposes, we should try to decrease neuronal excitation to prevent excitotoxicity, or rather try to stimulate neuronal firing to enhance recovery. We have used our TBI model, a closed weight drop mild TBI, in which a reliable and reproducible cortical lesion evolves in a small injury, a neuronal loss and gliosis over hours and days, to study this point, deploying a number of chemogenetic tools to increase or decrease the excitability of the cortical microcircuitry. So if we make an intervention at the level of parvalbumin interneurons, the major inhibitory interneurons in cortex, we see that if we increase PV activation, we produce a substantial increase in the size of the injury. Whereas if we decrease PV activity, we produce a substantially smaller cortical injury. And this is true in the first 30 minutes to 24 hours after the injury, but is no longer true more than 2 days after the injury. We confirmed this finding using a second chemogenetic system, a DREAD-GQ, through which we could increase the activity of the principal neurons themselves, and this generated a substantially smaller injury. However, when we suppressed completely inhibition, ablating PV interneurons, we obtained a massive increase in the size of the injury. So some degree of activity is necessary. Too much inhibition can be detrimental, but complete suppression of inhibition is also detrimental. So which are the mechanisms involved in activity-dependent modulation of neuronal vulnerability? We use genetically encoded calcium buffers to suppress the activity-dependent transcription in neurons. And this generated a massive increase on microglia recruitment, to our surprise. A transcriptome analysis of these neurons revealed a substantial downregulation of one soluble mediator, in particular osteoprotegerin. In fact, when we re-expressed osteoprotegerin, we could not only normalize microglia recruitment, but also protect synapses and neuronal loss. Most notably, osteoprotegerin is upregulated in the acute phases of traumatic brain injury in humans, providing translational validity to our observation. I would like to thank my collaborators, my students, my funding sources, and I would be glad to take questions.
Thank you so much for a fascinating talk, Dr. Roselli. I think we may have time for some questions, although I don't see any questions in the chat. Does anyone, I guess no one in the meeting can bring up any questions at this point. Really very elegant work. I'll make sure to read up more on your relevant papers. So I suggest we go on to our next talk, which is a basic science talk by Dr. Elisa Zanier from the Mario Negri Institute for Pharmacological Research. And the title is Experimental Models to Study Mechanisms Linking Traumatic Brain Injury to Neurodegenerative Disease.
Good morning. My name is Elisa Zanier. I work at the Mario Negri Institute in Milan, and I'm very pleased to be part of the brain meeting this year. My talk will focus on experimental models and how they can help us in understanding the mechanisms linking traumatic brain injury to neurodegeneration. I have no conflict of interest to disclose. And so there is large recognition that trauma sets in motion a number of dynamic processes that contribute largely to final outcome. I decided to start by briefly discussing this seminal study that was highlighting how TBI patients face an uncertain long-term future. So TBI patients were recruited and scored by Glasgow Outcome Scale 1 year after the injury and follow for an additional 5 to 7 years. Below you can see the different categories in terms of outcome. And if you look at the proportion of severe, moderate, or good recovery patients, these are in line in terms of percentages to figures at 6 months to 1 year after TBI. However, what was clearly shown here is that there are still a number of patients beyond 1 year showing improvement or deterioration. And this proportion is quite substantial, with about 25 to 30% of patients with late neurodegeneration. So this tells us that there are clear adaptative and maladaptative processes that are ongoing for a long time. In describing neurodegeneration, traumatic brain injury models can be very helpful. And this is true as far as they reflect, let's say, the key events that are observed in patients. And here is an example of a very well characterized model of traumatic brain injury in rodents called control cortical impact that reflects the main feature of brain contusion. After a severe trauma, similarly to what described in patients, we see a functional impairment both in terms of sensory motor and cognitive deficits that persist for months and even years after the injury. Furthermore, in terms of neurodegeneration, it also reflects what is shown in patients in terms of white matter degeneration. So we see a reduction in the thickness of the corpus callosum and other white matter structures, and white matter fibers are disorganized. So this means that we can take advantage of this model to try to understand better the mechanism driving the transition from TBI to neurodegenerative diseases. So we have a direct interest in this, and among potential drivers of chronic neurodegenerative pathology, we are focusing our attention on tau protein, which stands as a key candidate in driving this progression. In fact, the accumulation of phosphorylated tau and misfolded tau has been shown in patients years after either single or repetitive TBI, and this has been demonstrated in patients in vivo by imaging studies and postmortem. Tau is an hallmark of Alzheimer's disease, and in fact, in the report by the Lancet Commission in 2020, traumatic brain injury was included as a potentially modifiable risk factor for dementia. So that TBI in predisposed subjects accelerates neurodegeneration and AD is known since long time. However, more recently, experimental studies in rodents have also documented that in wild-type mice that are not prone to develop tau pathology, traumatic brain injury induces de novo tau deposition. And this is a study by the group of Kondo that was looking at a particular form of phosphorylated tau named cis-phosphotau, and they showed that a mild TBI induces a transient increase in tau deposition, and this was even more robust and persistent over time after a repetitive mild traumatic brain injury. And interestingly, a similar deposition of tau was detected after a single severe traumatic brain injury. So this suggests that the biomechanical load, rather than the type of impact, may be responsible for the emergence of tau pathology. With respect to the temporal and spatial distribution of tau pathology, we showed that tau-positive deposits can be seen only near the contusion edge 3 months after injury. But by 12 months, by a year after the injury, there is clear evidence for tau pathology in both the ipsi and the contralateral hemisphere, showing some degree of propagation. Here is a table from a very recent review paper published this year in Acta Neuropathological Communication. And the authors reviewed clinical and preclinical studies to further document whether there is substantial evidence for long-term accumulation of tau after a single moderate to severe TBI. I reported the tables with all the preclinical studies that were selected by the authors, and I think it's interesting to see that all studies documented the presence of tau at chronic time points after TBI. And this was true either in mice, rats, or transgenic models. So with the evidence that traumatic brain injury induces tau pathology, we were and we still are interested in understanding whether TBI-generated tau is pathogenetic or is more a biomarker of ongoing neurodegeneration that is driven by other processes. So we asked whether, similarly to what already shown in other disease contexts, tau generated by TBI may also show a prion-like behavior with the ability to propagate and induce functional impairment. And we did this together with Roberto Chiesa, which is a prion expert, and we performed a transmission study. So we inoculated brain homogenates from TBI mice 12 months after the injury, as well as from aged, matched, sham, or naive controls. Inoculation was performed in the hippocampus and overlying cerebral cortex of young adult mice. So to make a very long story short, we found that inoculation of mouse TBI homogenates induced memory impairment, but also synaptic alteration in wild-type recipient mice. And more importantly, when we look at the pathology 1 year after the inoculation, we found widespread tau pathology. So tau deposition was present not only at the site of the inoculation of brain homogenates, so namely the cortex and the hippocampus, but also in remote brain regions like the thalamus and the cerebellum. And this to us tells us that there also TBI-generated tau may display a prion-like behavior. So data show that self-templating competent tau is induced by a single focal TBI that progressively spreads throughout the brain, causing synaptic dysfunction and cognitive impairment. And the results suggest a mechanism by which an acute biomechanical impact may predispose to neurodegeneration. But is tau TBI really pathogenic? So to answer this question, we were looking for a more tractable model, because what I showed you so far was done in a model setting that takes years before showing tau accumulation. So together with Luisa Diomede, she's an expert in disease modeling in the C. elegans, we decided to exploit the C. elegans, which is widely used to investigate pathogenetic mechanisms underlying protein misfolding diseases, including tauopathies. And we established an integrated approach using brain tissue from our TBI mice and C. elegans to test whether TBI-generated tau has a pathogenetic role. We did this by exposing N2 young adult worms with the brain homogenates obtained from either sham or TBI mice. And this is what we observed. So from the movie, you can see that the number of body bends over time, which is a measure of the locomotor activity, in the worms treated with the sham homogenate was significantly higher than that of worms treated with TBI brain homogenates, indicating a specific neuromuscular damage after the exposure to TBI homogenate. In order to see whether this impairment could be ascribed to tau, we used several complementary approaches. So we asked whether TBI toxicity could be abolished by treating the homogenate with increasing concentration of PK to obtain protein digestion. And these are the results. So PK completely abolished the ability of brain homogenates to induce a locomotor defect. Next, we tested whether anti-tau antibodies could block TBI homogenate toxicity. And this is the effect of TBI brain homogenates pre-incubated with or without T46 antibody, which recognizes the C-terminal region of both human and mouse tau. So incubation with this antibody was able to prevent the motility defect caused by TBI brain homogenates. Next, we proceeded with the immunodepletion study. So nematodes were treated with sham or TBI brain homogenates previously subjected to immunoprecipitation with an antibody recognizing murine tau. And again, tau immunodepletion was able to abolish the motility defect. Importantly, what we also observed was that when we treated the C. elegans with homogenates from chronic TBI mice lacking endogenous tau, so from tau knockout mice, we could not observe any toxic effect. And here is an ongoing study that is run at my laboratory by Gloria Vegliante. She's conducting her PhD thesis on this topic, and she's testing whether endogenous tau is needed for transmitting tau pathology and developing cognitive deficits. So TBI homogenates were inoculated in either wild-type mice or tau knockout mice. This experiment started 16 months ago, and what I can anticipate are the results from the cognitive assessments. So what we observed was that by 9 months, memory was not impaired in either wild-type or tau knockout mice, with both strain of mice showing the ability to discriminate between a well-known and a novel arm and paying more attention to the novel one. However, by 16 months, we observed a memory deficit, and this appeared only in wild-type mice. So data indicate that endogenous tau is needed to induce memory impairment after the inoculation of TBI brain homogenate. We don't have the results of immunohistology, which is ongoing, but we have evidence from analysis in blood that there is an accumulation of tau at 16 months in wild-type inoculated mice. No tau in blood was detected in knockout mice, and this was expected. So, results suggest the mechanism by which the biomechanical impact predisposes to cognitive decline and neurodegeneration. And the next question is whether we can interfere with TBI tau propagation to improve outcome after TBI. And what we are now testing is whether we can exploit our combine TBI and C. elegans model to test new tau targeted treatment. And I can show you some preliminary results. So we started by testing this compound, which is an hexapeptide that was studied since a long time at our institute. It shows a potent pleiotropic effect and with the capacity to inhibit tau oligomerization, as you can see here. So we first tested the biodistribution of the hexapeptide after intranasal administration after TBI, and we found that it was still present 48 hours after the first administration in the brain, as you can see by the MALDI-TOF image. So we performed the first in vivo experiment by treating overexpressing mutant tau mice every 48 hours by intranasal administration. And we tested memory performance. So what we found was that the hexapeptide, as you can see here, was able to improve cognitive deficits. And next, we treated the worms with the homogenate from the treated and untreated mice. And what we observed was that as known, and you can see this in light blue, there was a toxic effect when the worms were treated with homogenates from wild-type mice. However, the toxicity was completely abolished and reverted after the in vivo treatment with the hexapeptide, so suggesting that our integrated approach may be useful also for testing anti-tau compounds. And with this, I would like to thank you for your attention and to thank my laboratory, particularly Gloria Vegliante, who performed most of these studies. And of course, all our collaborators at the Institute, the group of Roberto Chiesa and Luisa Diomede, and our international collaborators at Glasgow and Cambridge, and of course the funding bodies that supported us and allowed us to perform these studies. So thank you.
Fantastic. Thanks, Elisa. Great talk as ever. Lots to discuss. Please, if you have questions in the audience, please pop them in the chat. So a question from Ramon initially. Ramon wonders if you could comment on the cis-p-tau isoform and whether you think this is uniquely toxic as an isoform or just one of multiple toxic isoforms.
Yeah, so this was a beautiful findings by the group of Kondo already back a few years ago. My impression, because so far it's more an impression than evidence, is that this is one of the possible isoform that we can target in order to obtain protection, and probably the mechanism underlying the pathology is even more complex and could also involve the interaction between tau accumulation and beta deposition. So yeah,
I suppose a follow-on question is, if we think clinically, how are we going to sort of identify those patients at risk of progressive problems? I mean, there's a lot of movement in the space of blood biomarkers. Do you think we can pick up the relevant tau isoforms in the blood that are going to signify the risk of neurodegeneration going forward?
I mean, I think we are not there yet, but I'm really optimistic that this is one of the way to go, and probably it could be that we need to combine blood and imaging studies in order to have a better description of the evolution of the pathology. But I think that we could have some minimal invasive, let's say, way to monitor brain evolution and identify patients at risk.
Do you think there's a particular phosphorylated tau isoform that's going to be relevant in TBI? You know, like 181 tau seems to be particularly kind of predictive in Alzheimer's, for example. I mean, is there a phosphorylated tau isoform that, you know, will help us predict outcomes following TBI?
Probably the true answer now is that I don't know yet if there is an exactly which one could be, but there are a few forms of phosphorylated tau that may contribute to this. So it would be important to develop specific assay to measure different forms of tau. And something that I also think is that it could also be that we need to combine multiple markers in order to identify a pattern that will inform us on injury evolution rather than a single one.
Great. Okay, so let's wrap up there. It's a really important area, and it's fantastic, you know, basic science work. So thank you again for presenting it. So our next talk is a data blitz from James Ruffle at UCL. He's going to be talking about exposure to concussion and the relationship to brain structure and function. So let's move on.
Good afternoon. Thank you so much for the opportunity to speak today. My name's James Ruffle, and I'll be talking about our research showing that engagement in competitive sport and exposure to concussion affect both brain structure and function. This is a study in collaboration with both the International Concussion and Head Injury Research Foundation and University College London. Mild traumatic brain injury is a leading cause of disability linked to both neurodegeneration and dementia, and the commonest cause is a sporting exposure, reported frequently in the press. So here's an article from July 21, after UK Parliament had discussed overhauling the sports concussion protocols, and another from now a few weeks ago of a player who ended his playing career having sustained multiple episodes of concussion and subsequently debilitating neurological symptoms. And there's mounting evidence in the neuroimaging community that there are brain structural changes that occur in these individuals, such as the article here from Professor Sharp's group of white matter changes. And so the aim of our study was to investigate the neural effects of such injuries with complementary imaging modalities. So we reviewed and studied 125 retired professional competitive athletes paired against 36 healthy controls, and these two cohorts did not differ in age or gender. And we reviewed the brain imaging of these individuals and studied them with parcellation, segmentation, and volume with geodesic information flows NIFTY-SEG. And then we statistically compared these with Bayesian logistic regression models. We then used these findings with meta-analysis of natural language processing of all previous brain imaging studies with software NeuroQuery. We identified an array of areas that were smaller in the athlete cohort, and this included the middle frontal gyrus, the hippocampus, the supramarginal gyrus, the temporal pole, and the inferior frontal gyrus. But we also identified an array of areas that were larger in the athlete cohort. This includes the hippocampal and collateral sulcus here, commensurately enlarging, one would imagine, because of the decreased hippocampal volume, but also multiple other areas including the middle occipital gyrus, the medial orbital gyrus, the caudate, and the medial segment, the postcentral gyrus. We then undertook a natural language processing meta-analysis of more than 13,000 neuroimaging original articles to relate our volume differences between the athletes and controls. This identified areas that were putatively functionally enhanced and attenuated in the athletes. Firstly, those areas attenuated on the right of this figure dominate around memory and language, but also those areas functionally enhanced predominate around motor, sensory, coordination, balance, and visual processing domains. And so, in wrapping up, we conclude that engagement in competitive sport plausibly benefits the brain in numerous domains, but also must be protected from the damaging effects of concussive head injury. Thank you so much for listening. I'd be happy to take any questions.
Great, James. Thank you very much. Very clear talk, really nice presentation. Very interesting challenge to try and work out which players might be at risk downstream. I wonder. I mean, it's very intriguing that you identify some areas that are smaller, some areas that are larger. What can you just say a bit more about what you think the mechanism of those volumetric changes might be? Particularly in terms of the enlarging.
I think it's really interesting because from the outset of this study, its aim was to investigate the effects of concussion. So by no means did we expect we would see this kind of mixture of both things that are getting bigger and those that are getting smaller. And I suppose when we sat down and looked through the results, the thing that is the character of this athlete cohort is they're all individuals who have had lengthy playing careers who are now retired, so have painstakingly trained for years and years on end in their given sport of choice, who nonetheless have then sustained episodes of concussion. And so the fact that we then see these kind of enlargement in many sort of motor and processing areas of sort of perception that then obviously fit with our meta-analysis, but then is offset by the sort of factor of them having concussive head injury with decrease in volume in other areas, we think is kind of the result for that. So these individuals with enhanced sport abilities, perhaps from their years of training, has contributed to those increased volumetric changes, is what we perhaps think.
Okay, but this is a related question possibly. So from Judith Allenson, just to finish off with, I wonder if you were able to control for the self-selection involved in the people taking part in the sports, i.e. is it due to more coordinated people becoming athletes? I mean, that relates to what you were saying before, but
it's a super question. Yeah, no, it's a really super question, and I wish I could say absolutely we did, but no, we couldn't, because of course, we've identified this cohort of people who had already made it, who had made it to the professional careers, had lengthy careers as a consequence, and then it's compared to these kind of neighborhood controls who are doing exercises of the general population, but are undoubtedly perhaps not as coordinated as the professional athletes. So no, we weren't able to, but that's certainly another possible explanation for why we see some of those differences in the cohort. So it's a really great point that's raised.
Good, James, thank you very much. Excellent talk. We're going to move on now. So the next talk is from Ramon Diaz-Arrastia, who you've heard from before, chairing the previous bit. He's going to talk about TRACK-TBI and the big data that's being generated by that study. So it's a tremendously exciting time at the moment in TBI research with some very large data sets coming online. So we're going to hear from that from Ramon now.
Organizers to give a talk on recent big science, big data projects in traumatic brain injury, and I've decided to title my talk Paradigm Shifts in Traumatic Brain Injury, Lessons from Big Science. Let me start by a historical note, and I would like to make the point that traumatic brain injury is really one of the oldest and most common maladies affecting humanity. The Edwin Smith Surgical Papyrus, in many ways, the first medical text, was in large part a textbook of trauma surgery. And patient number 9 in the Edwin Smith Papyrus was an individual who had suffered a traumatic brain injury from a wartime injury, resulting in hemiparesis and impaired consciousness. Quantitatively, studies in physical anthropology over the last several years have found that somewhere between 15 and as much as 40% of all skulls found in ancient burial sites have evidence of healed skull fractures, or in some cases, lethal skull fractures. It is very clear from the anthropological record that our ancestors lived in a state of constant warfare with one another, and bashing each other in the head, they found out was a pretty convenient way of incapacitating your enemy. So TBI is an experience that humanity has had really from the very beginning. And I want to make the case that over the last 10 to perhaps 15 years, we have entered into the golden era of TBI research. And there are a number of reasons for this. In general, society has awakened to how common and how disabling these conditions are. And at least in the United States, one reflection of that social interest is reflected by the increased funding related to research in traumatic brain injury. This slide shows data from the National Institutes of Health from the Department of Defense, as well as from the Veterans Administration, showing that really a very dramatic increase over the last 12 years or so in funding going to traumatic brain injury. This has been a very exciting time. It has brought a lot of new talented investigators into the field, has allowed us to use very exciting cutting-edge techniques. And today I'm going to be summarizing at least some of the key conclusions of all of that work. So what I'm going to be talking about is really 3 paradigm shifts in traumatic brain injury medicine. These are things that go beyond just a single paper or a single finding, but it's actually how the field overall has shifted on how we think about these conditions. So the first paradigm shift I'm going to be talking about is the issue that mild TBI is not always mild, or in a more general sense, making the case that the current nosology by which we assess TBI severity is inadequate and misleading and really is not helping in the development of future therapies. Then going to talk about how magnetic resonance imaging, particularly more advanced tools of MRI, are revolutionizing TBI medicine. And this should not be a big surprise. MRI has revolutionized every other area of clinical neurology. It's been late in coming to TBI medicine, but it is here now, and has provided and will continue to provide very important insights. And then finally, I'm going to talk about how proteins measured in the blood with new ultrasensitive analytical techniques have given us important insights into pathophysiology of TBI and how they will be used and will revolutionize clinical research and clinical practice. Now, most of the studies that I will be citing are results from the TRACK-TBI effort. TRACK-TBI is a consortium in the United States. We now have approximately 18 clinical sites. Most of the, not all, but most of the clinical sites that are very active in TBI in the United States are part of the TRACK-TBI consortium. I've been involved with that since its inception, and therefore most of what I will be citing will be related to TRACK-TBI. But I will also be talking about some work from the Center TBI Consortium, which is a somewhat larger effort that was conducted in Europe, largely in parallel, not exactly symmetrical, but largely in parallel to TRACK-TBI. It was done that way by design in order to allow cross-comparison between results. I'm then going to talk about a little bit about the reactive project, also conducted in Europe. And finally, I'll have at least a couple of slides about the NCAA CARE Consortium, which is a collaboration between the National Collegiate Athletic Association and the Department of Defense, focusing on a part of traumatic brain injury that is not otherwise a big focus of my talk, meaning sports-related concussions, or really kind of the mildest of the mild of these TBIs, which nonetheless are not always trivial and should be paid attention to. So let's start off with the first paradigm shift. Now, this is the concept that mild TBI is not always mild. And this is something that has been considered for a long time, but really only with these large, prospective, carefully conducted observational studies do we really have some hard numbers that we can hang our hats on. So this is a study that was published a couple of years ago by Lynn Nelson and her colleagues from the Medical College of Wisconsin. And they looked approximately 1,500 patients with traumatic brain injury who presented at a level 1 trauma center in the United States. Now, this may not be a epidemiologically robust cross-section of TBI in the United States, because we're looking at people who come to level 1 trauma centers, so more minor TBIs or TBI who never went to the emergency room or perhaps went to a community hospital would not be reflected here. But within this cohort of people showing up to level 1 trauma centers, 80% or so of them were, we're looking here at people who were GCS 13 to 15, which is the traditional definition of mild TBI, and of those, 78% were GCS 15, meaning that they were fully following commands. Really nothing on the GCS suggesting much of a severe head injury. Now, 65% of these were admitted to the hospital, not always because of a traumatic brain injury. Some of them had polytrauma. In fact, quite a few of them had polytrauma. That may have been the reason for admission to the hospital. 69% of them had a negative CT scan, right? So even many of the folks that were admitted to the hospital had negative CT scans. And a very important feature of this study is that we also enrolled in parallel and followed in exactly the same way almost 300 individuals who had orthopedic injuries who were matched by age and gender and roughly by AIS to the level of severity of the TBI cases. Now, when they were followed a year later, 53% of the TBI cohort reported some degree of limitation in their daily life. And most commonly, this was limitation in being unable to go back to work or being able to go back to work, but in a limited capacity, or also some limitations in social and leisure functioning, some limitations in family disruption. In comparing it to the orthopedic trauma controls, the risk of injury-related limitations was higher in the TBI cases, with an odds ratio of approximately 1.4. More recently, we have been following up these mild TBI cases for approximately 3 years after their injury. We are conducting telephone interviews, which allow us to obtain the Glasgow Outcome Score Extended, which is a functional outcome measure, the brief telephone assessment of cognition, or the BTACT, which gives us a measure of cognitive function, as well as the BSI-18, which is a self-reported questionnaire of post-concussive symptoms. And the findings, and these are being prepared for publication, is that somewhere between 15 and 25% of these patients have experienced a decline between the 1-year outcome assessment and the 3-year outcome assessment. So not the majority, but a substantial number. And given that the epidemiological data that suggests that in the longer term, meaning decades after TBI, there appears to be an increased risk of dementia or other cognitive disorders, I think we're finding some evidence of early changes along those lines, again, emphasizing the point that mild TBI is not always mild. Let me move on to the second paradigm shift that I wanted to emphasize, and that being that magnetic resonance imaging will revolutionize TBI medicine. Again, I want to highlight a couple of recent studies from the TRACK Consortium. This is an important study published several years ago, looking at resting state functional networks in patients with traumatic brain injury. And these were studied 2 weeks after injury. And the finding is that regardless of which resting state network one is looking at, whether it be the default mode network or whether it be the executive control network or the frontoparietal network, there appears to be a loss of focus of the network, meaning that there is a greater cortical area that gets recruited into the network, but the areas at the core of the network where the network is focused in healthy individuals, there's a decrease in connectivity right at that level, which is shown here in blue as opposed to shown in yellow. There is the increased activity in the surround, while decreased activity in the very core of the canonical network region, suggesting that TBI patients are having to recruit larger volumes of cortical surface in order to maintain the same level of task activation as the uninjured subjects. And this is a very elegant technique, which I think promises to help us understand much about the pathophysiology of TBI. This, by the way, happens in even people who are CT negative and structural MRI negative. So meaning there are no visible focal lesions at all, there are still deficits in this resting state functional connectivity that can be detected. More recently, and this is again work from Pratik Mukherjee and his colleagues. Pratik leads the TRACK-TBI neuroimaging core. He has used a advanced diffusion method called neurite orientation, dispersion, and density imaging, or NODI, which is a more sophisticated way to look at diffusion data. And then there are important findings that came from that was published recently, right? So again, it confirms the finding that many other labs have shown, that there is a reduction in fractional anisotropy and an increase in mean diffusivity. But importantly, there is also a reduction in neurite density and an accompanied increase in the free water fraction. So these are novel findings, and these two measures, meaning the neurite density and the free water fraction, appear to be more sensitive, and the abnormalities there are more, more readily apparent than the abnormalities in the traditional DTI metrics. And the other finding that Pratik and his group were able to find is that these abnormalities progress over time. So between 2 weeks and 6 months, there is progressive disruption of these white matter tracks that can be measured with these diffusion metrics as well. And again, this is a promising tool that has the potential to revolutionize clinical research and clinical practice. Finally, let's switch to the third paradigm shift that I want to talk about, meaning the role that blood biomarkers, proteins that can be measured in the blood with ultrasensitive techniques, will have a role in TBI medicine. Now, unlike the heart or the kidney or other organs where blood biomarkers are fundamental in the management, the clinical management of these conditions, the brain, because it's a much more complex organ, it has many different cell types, it is likely that we will need a panel of biomarkers in order to fully understand what is going on as a consequence of these injuries, right? The proteins that are made by cell bodies are going to be different from the proteins that are going to be made in the synapses. They're going to be different from the proteins made in the axons. Certainly proteins made in glial cells or in vascular cells will be different still. In the United States, and this has happened within the last couple of years, the Food and Drug Administration has cleared 2 protein biomarkers, meaning GFAP, glial fibrillary acidic protein, and UCHL1, ubiquitin C-terminal hydrolase L1, for aid in the diagnosis of mild traumatic brain injury. And the Abbott test has been cleared in this point-of-care handheld iStat device, which can provide results within 10 or 15 minutes in the emergency department, in the ICU, and this will very likely really revolutionize medicine. We've looked at that in the TRACK-TBI cohort, and these are looking at a subset of the TRACK-TBI patients who had MRI. And just to summarize the findings, we had approximately 760 MRIs that were done in 2 weeks. 455 of those had negative CTs, and of the ones that had negative CTs, 122 had positive MRIs. Not surprisingly, MRI is substantially more sensitive for some of these trauma-related abnormalities than CT is. This is the case really in all of clinical neurology. But the important finding that we've had, and this was published in Lancet Neurology a couple of years ago, is that there is a relationship between the elevation in GFAP levels measured in the blood with the abnormalities that are noted. Orthopedic controls, as expected, had very, very low GFAP levels. Even those whose CT scans were normal and that the structural MRI was normal, they had elevated GFAP levels. So this is not an absolute measure, right? There is still some degree of head injury, even in these structural imaging negative cases. On the other hand, those where the structural imaging showed abnormalities, meaning that the CT was abnormal or the MRI was abnormal in several different ways, GFAP levels was higher still, indicating that these blood biomarkers are giving us information that is complementary, but more than complementary, is giving us additional information that the neuroimaging itself does not show. The Center TBI project had very similar results, and this was published again a couple of years ago. They looked at a number of biomarkers, and importantly, they were able to show that the addition of GFAP to the clinical decision rules significantly improved the classification of whether an individual is going to be CT positive or negative, indicating that these biomarkers are giving us additional information beyond what would be available, standardly based on the clinical decision rules. The NCAA CARE Consortium, and now this is studying sports-related concussion, which is the mildest of the mildest TBI, is nonetheless an important study. And I wanted to show this because it illustrates some important features about these blood biomarkers. So these investigators enrolled over 1,700 collegiate athletes and service academy cadets, and over a 3-year period, approximately 264 of them suffered a clinical concussion syndrome. And then these were compared with athletes in contact sports who were not concussed, and they were also compared with athletes in swimming or track and field that did not involve contact. Blood was collected at baseline, and it was collected several times after the clinical concussion. And the finding of this study is that particularly for GFAP, but also for UCHL1, there was an almost immediate increase, highly statistically significant, in the blood biomarker levels of both of these proteins, and generally went down relatively quickly. By 24 hours, it was back to normal for UCHL1. It was still somewhat abnormal for GFAP, but generally resolved by the time that they were asymptomatic or able to return to play. Really not in this particular study, again, looking at everybody who had suffered a clinical concussion, not much had shown up from the point of view of neurofilament light or this other protein tau. On the other hand, if they focused on those that had the somewhat more severe sports-related concussions, meaning sports-related concussions that were associated with either loss of consciousness or post-traumatic amnesia, a different picture emerges. First of all, the elevation in GFAP and UCHL1 is much higher, but in particular is the elevation in neurofilament light that I think provides really very important information. In these more severe sports-related concussions, there is an elevated neurofilament light that can be measured acutely. It then comes back down somewhat by 24 hours, and this is a reproducible finding, which is somewhat not trivial to explain. But most importantly, it appears that there is an increase in neurofilament light over the subsequent several days. And even as the symptoms resolve, and even as the athletes return to play or return to their normal activities, the elevation in neurofilament light does suggest that there is perhaps something still at the level of the brain tissue and the level of the cellular processes that is not fully recovered. And I think it has very important implications to how we manage these injuries in the future. Finally, I wanted to highlight this important paper that was published last year, and these are from collaborators in the reactive project, who also called it the BioAct study. This is a study conducted in several trauma centers in Europe. They enrolled 195 participants. Now, this was all moderate to severe TBI, but what's important about the study is that they found a very nice correlation or relationship between the fluid biomarkers and the imaging measures of either gray matter atrophy, measured here by the atrophy rate using the Jacobi determinant, or more standard DTI measures of axonal disruption, meaning fractional anisotropy into corpus callosum. So for both NFL and tau, there does appear to be a relationship. And this is important because it tells us that these biomarkers are actually measuring the atrophy and also the axonal disruption that can occur, and that we're measuring with MRI as well. And the correlation between the two gives us confidence that we're measuring something important. In conclusion, I hope I have convinced you that the current classification schema for TBI are inadequate for the development of effective therapies, particularly so for the so-called mild TBI spectrum. I hope I've convinced you that advanced neuroimaging methods have now been validated in large, adequately powered cohorts, and the future of TBI medicine will inevitably include MRI imaging. Additionally, some biomarkers have already been cleared in the US by the Food and Drug Administration for use in the management of TBI, and it's likely that others will be cleared in the next several years. And a complement of blood biomarkers is going to be very, very helpful for us. Again, thanks so much for your attention. I'd like to thank not only the organizers in the TRACK-TBI consortium, but really a group of very talented colleagues that works with me at the University of Pennsylvania. And hopefully we'll have time for some questions.
Great, thanks, Ramon. Amazing amount of work, and congratulations on pulling it all together over all these years. And it's an enormous effort. But it's brilliant to begin to see, the kind of fruits of all that labour coming together, I think. And as you say, it's an exciting time at the moment, isn't it? We've probably got time for one or two questions, if there's any that come through. Just at a high level, I mean, I completely agree with you about the taxonomy, if you like, the problems of the dichotomy really between mild and, more severe injuries is very difficult in all sorts of areas. What should we do differently? What should it be replaced? What should we replace it with?
Guys, it's a great question. And, we really need to get rid of the term mild TBI because it really isn't mild for a subset of people, certainly not the majority. I mean, I like the term, which actually was proposed in a paper that Olli Tanuvu proposed a while back of kind of, low risk, medium risk, and perhaps high risk. Right, because what obviously people really care about is the long-term consequences of that, and it is true that people who get bonked on the head and perhaps passed out, had a brief loss of consciousness, brief post-traumatic amnesia, they generally do pretty well. We also don't want to scare people unduly. On the other hand, we don't want to tell them they're all going to recover when somewhere in the order of 15 to maybe 25% do not. So I think I like the term low risk TBI a little better, and also it implies, because a fraction of these severe TBIs actually do make very gratifying recoveries, right? So maybe we should be, instead of calling it severe TBI, we should be calling it high risk TBI, implying that, and I'm actually curious if Brian's still on, what he feels about this, right? Because we do know people who are often in coma for a week or more. Sometimes they make very, very gratifying recoveries, and certainly we are concerned that sometimes people are unduly pessimistic in some of these folks and maybe pulling the plug a little earlier. So that's kind of my sense.
Great. Well, perhaps we've got two very good questions, and maybe we could just have really brief answers, Ramon, because we're about to get shut down, I think. The first is from Ramon Sakuja, who says the dynamics of these biomarkers share a lot with neurodegenerative conditions such as Alzheimer's. Are we at the stage that we can use them to differentiate pathologies in that context, do you think?
I personally don't think that the biomarkers are going to be useful to differentiate pathologies. Right? We're still going to need neurologists to tell the difference between these different syndromes. I think the biomarkers are telling us what's going on at a molecular and cellular level, and there are going to be some commonalities, whether it be TBI or whether it be stroke or whether it be multiple sclerosis or a neurodegenerative disease. And I think that's inevitable, and I think we're going to need a neurologist somewhere along the line to make the diagnosis, and the biomarkers are actually going to be helpful for prognosis and monitoring therapy, et cetera.
And if I could squeeze in one last question from Neil Graham, who says, thanks for a fantastic talk. Interesting to hear your speculation about the odd dynamics of NFL, and the fact that they're increasing over the first week. So
it's really interesting. So I guess one possibility, and to be honest, we don't completely know, it's just that it may have very, very long pharmacodynamics, right, or pharmacokinetics. It may be that it just takes a long time to clear this particular protein for reasons that we don't completely know. I think the other concern is that even when there has been resolution of symptoms, though, that there is still some ongoing axonal rewiring, axonal disruption. And you wonder, should we be requiring that people's NFL level get back to normal before we let them go back to play? I think that's one of the implications of that finding. I don't think we really know yet. We need to learn a lot more about the pharmacokinetics of NFL in particular, but also about what's going on in the level of the axons that have been impacted, and when do they fully recover? And it may be that the full recovery at the tissue and axonal level may be delayed by several weeks after the symptomatic recovery, and it may be dangerous to let people go back to play and put them at risk of further head impacts when the axonal recovery hasn't totally completed yet.
Okay, that's a great point to finish. A very unpopular for the sporting clubs, I'd imagine, that kind of idea. But let's stop there. But I want to thank all the speakers. It's been a great set of talks. Really, thank you for coming from all over the place, and thanks everybody for listening. We'll wrap up there and move on to the next session, I think.